All right, okay. Can the current group come on video, please? Right, okay. Okay, children, welcome to the next session. And a lot of you all wanted to talk about IUGR or small for gestational age. I don't know, there was a lot of generated interest in it. So we have been doing a lot of obstetric topics. So anyway, let's do small for gestational age, right? And IUGR. Okay. Now, right. Who is just messaging me? We are from the 28th batch. I did not ask anyone. Okay. Right. Okay. So it's fine. I mean, anybody can join. Doesn't matter which batch. Okay. Doesn't really matter. So, okay. Now, if we look at small for gestational age, right, as an entity, now there are two terms that you need to understand. One is what is intrauterine growth restriction, that is number one, and the other is what is small for gestational age, right? These are the two things that you need to understand very clearly before we move on. Okay. Now, when the baby is inside the uterus, right, it's a unique being. There is no other person like that. The genes are unique because it's a combination of the maternal and the paternal genes, right? And each of this baby has a genetic potential to grow to whatever size it wants to, right? Because with that, the baby has growth factors like insulin growth factor 1, insulin growth factor 6, all these are produced. Tissue formation is governed by the baby's genetic setup, right? And so the baby carries a genetic potential. And if it is given the right environment, because about the end product or the size of the baby is determined by about roughly 40% genetics, 60% by the intrauterine environment. Okay. So if the proper environment, right, is provided to that baby, right, with its genetic potential, the baby is able to grow to whatever genetic potential it has. Okay. But we will never be able to measure, maybe in the future, I don't know. For the moment, we cannot measure a baby's genetic potential by looking purely at the genes, because there's such a combination of factors that is taking place, right, to make the baby grow. Okay. What are these? Now, what are the genetic factors? The genes determine if it is normal or abnormal. The genes will determine, okay, the baby's growth factors, the tissue formation, how it creates its own placenta, because the placenta is a baby's organ, right? So, and how the placenta interacts with the mother, because it has to interact with the maternal uterus to get its nutrients. And there are so many things governing the transfer, amino acids needs to come, the fatty acids needs to come, the glucose needs to come, the other electrolytes needs to come, the other hormones need to come, everything needs to be transferred from the mother to the baby. But that's not enough. This substrate that is transferred needs to be transported back to the baby and it needs to be utilized. So that pathway also needs to be determined properly, right? Then tissue formation needs to happen, right? At the same time, so the mother will supply blood, nutrients, substrate, sometimes some growth factors, right? And so the mother also does something, the baby also has. So this whole thing coming together, right? The maternal, placental, and the fetal factors all coming together will determine how the baby grows. You all understand, children? So it is not just only one, right? Say, we cannot increase one thing and expect everything else to fall in line, which means we cannot feed the mother more, give her more substrate, thinking that the baby is going to become bigger. So that has not worked out because so many historical things where nutrients were put into the amniotic fluid, nutrients were supplied to the mother to try to make the baby grow, but that has not, because it's an interchange or interplay of three main areas, right, that causes the ultimate growth or the ultimate end result. Clear? It is what? The mother's cardiac output, which supplies blood. Remember, at 10 weeks, the mother gives, when the baby is 10 weeks, the mother gives about 50 ml per minute. At the end, by term, the mother is giving 1,300 milliliters per minute into the placenta, right? 50 ml at 10 weeks and 1,300 ml of blood at 40 weeks. So the mother also must pump blood. The mother's cardiovascular system also must go up. The mother's blood volume also goes up by the cardiac output also goes up. Everything, I have told you this before, right? Everything goes up to pump blood. So the mother is giving blood, the mother is giving substrate, mother is giving all this. But however much is given, if the placental intersurface is not working properly, that is a fetal organ, right? And it is also determined by the baby's genetics, genes. Then whatever, it is not going to cross. Even if it crosses, then the transportation hormones, the transportation proteins, right? All this must work to get the substrate into the placenta, and that again must be transported to the baby, right? But even if the baby gets all the nutrients, substances, everything, right? All the growth hormones, everything, the tissue formation factors, everything must work together to form the baby. So it's a very complex interplay, which we really don't understand how things happen. So we are actually sort of, going around scratching the surface as to how all this interaction happens. Okay. Mainly, now, the biggest problem when you are looking at all these things is the question, okay, how do we find out whether the baby is in trouble and what is the best time for us to get the baby out so that it survives? But mere survival is also not enough. We need to figure out the baby should come out with the best of health. Baby should not be having cerebral palsy. The baby should have long-term, proper growth, that is after the baby comes out. Intelligence, right? Needs to function properly in the world, should not be having any long-lasting diseases or health problems, right? So therefore, all these factors come into effect when we have to make a decision as to when the baby must be delivered, right? So intrauterine growth restriction is the baby going up to its genetic potential. Simply put, it's like this. Say if a baby, if given the correct environment and all the factors, and if it realizes its genetic potential, say at 40 weeks, if the baby's weight should be 3,400 grams, but due to all the other factors that are working on it, the maternal factors, placental factors, right, everything, the baby reaches only 2,800 grams, the baby has intrauterine growth restriction because baby has not realized his genetic potential. You all understand? So whatever charts we use to plot, right? Sometimes when we plot, if we take single values, we plot them, the weight is normal, but actually the baby has growth restriction because it does not realize its growth potential. However, genetic growth potential. However, we will not be able to measure it. Okay? So only thing which we can measure or look at it is the baby's growth, which we call, and if the growth is not appropriate to that gestational age, we call it small for gestational age. Now, small for gestational age means, yes, it is combined with the genetic potential. But what we are doing is we are taking two values, the abdominal circumference, right? Because the abdominal circumference is the cut through the baby's liver. And the baby's liver is something that stores glycogen. And if the baby is having problems and the baby is become small and is not growing, the first thing that shrinks is the liver because the glycogen is used up. Okay, so the AC will become smaller. And then the overall, because there's a problem, the overall, the baby, if you take the estimated fetal weight, then the baby becomes smaller. Okay, so now when we plot these two, when we take these two values, and when we compare it with the rest of the population of babies at appropriate gestational ages, right? Which means in the chart, we know, okay, at 32 weeks, almost all the babies are in the normal distribution between the 10th and the 90th percentile. All the babies should have this value, okay, this weight, and the abdominal size should be this. So we have a chart and we have a line which shows the 10th centile and we have a line which shows the 90th centile, right? And when we measure at a certain gestational age and we find the abdominal circumference and the estimated fetal weight, the estimated fetal weight has four things working for it, right? What is it? The head circumference, the biparatal diameter, the abdominal circumference, and the femur length. So everything is taken into consideration, and the estimated fetal weight is calculated by a formula. And when we take these and we plot it on chart, we look at the period of gestation and we plot it on a chart. If that baby at that particular time falls below the 10th percentile in the chart, then we call it a small for gestational age fetus, right? That does not mean that there is a problem. That does not mean that there is a growth restriction or a problem. That does not mean that the baby might be having trouble, right? We do not know. But the understanding is that these small babies may be having growth restriction and problems, right? However, small babies which you find, most of them are just small babies. Normal small babies. They're just small. So almost 73%, 70% of these babies who our charts pick up as saying small are normal. That are normal small babies. Do you understand? So, which is good news, because there are not a significant number of the babies which we say, okay, these are small, are really normal babies. So, which is actually very good news. It is the rest of the people, 30, 27%, 28% of the babies, right, which we find as small for gestational age in our charts, are the ones that can have problems. But what do we do? Because initially, when we find these babies or small for gestational babies, we do not know whether to which category they fall into. And what are these categories? There are normal small babies, okay? And there are abnormal small babies. What does that mean? These are the babies who are having defects. They may be having genetic problems like trisomy, triploidy. Triploidy is where there are 69 genetic chromosomes. They may be in trisomy, maybe 21, 18, 16. There may be maybe sometimes Turner syndrome, right? There may be deletions of some genes. So all these may have genetic problems and they're abnormal small babies, right? Due to the genetic factors, right? And then there's another group, which are small, but they're small due to placental insufficiency. There's a problem with the placenta. 80 to 90% of these babies, right, from this group, right, most of the problems are caused, or the mortality, morbidity is caused by the baby or by babies that are having placental abnormalities, right? So again, remember, I just want you to understand there are three large groups. There are, of course, subgroups there. Three large. What are these children? Number one is of all the small for gestation. Now, remember, IUGR is a concept. We won't be able to ever measure the genetic potential. Okay, so we have to go by pure measurements of small for gestational age. Okay, when we find a small for gestational age baby, the baby can be one of three, right? What are these? They are normal. The placenta is also working normally, right? They are getting their substrate normally. They are just small, and that is the majority, which are happy. Okay. The second group are the ones who may have problems. They may be having defects. They may be having heart problems. They may be having different anomalies. They may be having different different genetic problems. Those are abnormal small babies, but their placenta is working well, normal, right? But they're small. And then the third group are the ones that we need to watch out for. Is what? Are the ones with problems, and those are the ones with placental insufficiency. Okay. The normal small babies, even if they find them, will grow along a normal trajectory. They will just grow along a normal curve. And those are the normal small babies. The abnormal small babies also will grow, say the second, third centile, but they will grow along that. Because it's only the genes that are making the baby proper small, right? So therefore, they also will grow along this trajectory and a line. But it is the babies with the placental insufficiency who is going to have the growth and problems, and those are the ones that can die inside and have problems. And even if they come out, they will be having a lot of perinatal morbidity and mortality, right? So these are the ones we are trying to catch, and these are the ones we want to deliver on time. And that is why we have surveillance. Just because we have a one spot measurement saying, okay, the AC is below this, and though these are small for gestational age fetuses, but we need to look at all of these, and we need to have a surveillance plans along the pregnancy to find out exactly which category this baby is going to. And if they are doing badly, then we take them out. You all understand? Right? So that is the purpose of looking or doing fetal surveillance in the antenatal clinic to find these babies and then deliver them appropriately at the right time so that the babies do not die inside the uterus. Is that clear, children? So that is the introduction which I wanted you to understand. So in summary, I want you to understand that there's a concept of intrauterine growth restriction because the baby does not reach its genetic potential. Is that clear? Right. Then the concept of small for gestational age is, yes, intrauterine growth restriction can be due to various things, right? It can be due to genetic problems, right? The baby may be restricted. So the restriction might happen, right? But then the concept, what we can do is that we cannot measure genetic potential. So therefore, we are measuring the growth. And therefore, when we measure the growth, and if the baby is small, we call it small for gestational age. So that is why we are actually looking at small for gestational age practically. Is that clear? Right. When we find a baby not small for gestational age, the overall, what we do is, right, we start a surveillance plan. Right? We start a surveillance plan to survey or monitor these babies. So we actually deliver these babies at the right time. Right? So that is what we do in antenatal care. Is that clear, children? Right. Now, let's see. Now, the whole thing revolves around one thing. Now, when we sit in the antenatal clinic, children, right? So we cannot just, okay, looking at all the mothers, we cannot do ultrasound and everything for every single mother, because most of these mothers are low risk mothers, right, with no problems. So therefore, the Royal College of Obstetricians and Gynecologists has one, and there are many guidelines because we usually follow the Royal College of Obstetricians and Gynecologists, has come up with a system. It can change, but there are minor changes only, right? Where detection and management is formulated into a plan. And that is what we need to understand now, right? So what happens? Initially, what is the aim? The aim is to catch the babies, fetuses who are at risk of having problems, and then initiate a plan of surveillance. Is that clear? Right? From the booking day, when they come into the clinic, you assess the risk, right? And then if there is at risk category, then they are put into a surveillance system, right? Basically, screening of a problem that is going to happen is done at the booking visit itself, where we try to catch the women whose babies might develop small for gestational age in the future. Is that clear, children? Right? For that, I will now, after this, once I put in the recording, I will put the chart, right, where the risk categories are explained. So in the booking visit itself, the risk categories are checked. And then the mothers are classified into women who need surveillance about their babies and women who do not need them, or low risk and high risk, right? So what happens is, in the history itself, there are two large categories, right, where the baby or maybe small for gestational age. Number one is, we can look at the history of the mother, right, and say, okay, this woman is at risk of having a baby with SGA. Second thing is, second large category is, if the women develop problems along the way, like pregnancy-induced hypertension, like the gestational diabetes, then also they fall into the category of having a small for gestational age baby, right? So therefore, there are two large risk categories. Initially, the first category is where the woman is the history is asked, right? And they are categorized into risk factors. Now, all these risk factors, children, are categorized into minor risk and moderate risk. Okay, so we have to take one by one, right, and find out which has a moderate risk and which has a minor risk. So in summary, at the booking visit, if the woman has 3 minor risk factors, then surveillance is initiated. Okay, or if the woman has 1 moderate risk factor, then also the surveillance is initiated. Right? So this is the plan in which we normally go about. Is that clear? Right. So I have this graph up, right? I will share my screen with you so that you understand these risk factors. I will quickly go through it and I will put this up later for you all, right? For you all to understand these risk factors which we look at during the maternal visit, right? Give me one moment. Can you see my screen, children? Right, okay. Can you see this? Yeah. Now look at this, right? Summary of risk factors for a SGA neonate. Okay. I will put this up. You don't need to write. Try to understand this. So what happens is, when this woman comes, you basically, there's a tick box, all right? And you can see on this side, if you look at this, available from history at booking. At booking, you survey this, okay? And look at this one, current pregnancy complications. So there are 2 large groups, children, right? If you look at that, you have current pregnancy complications and here you have booking history. And here you have the risk category, and here you have the risk, and here whether the risk is minor or moderate. Okay, got it? Now look at this. All right. So let's go to current pregnancy complications, B. Okay. Almost all these are moderate risk factors for developing small for gestational age. If there was a threatened miscarriage in the first trimester, then the chances of the woman having small for gestational is moderate, right? If there's a fetal anomaly, especially if there's echogenic bowel when you do the scan, right? Then of course they have a risk, right? Preeclampsia is a risk, PIH is a risk, placental abruption risk, unexplained APH is a, right? Lot of coffee drinking is a risk, right? And very small mothers, right? Low maternal weight, and if the mother is not gaining weight, that is also a risk. And of course, Down syndrome markers we don't do, but if the Papa A is less than the 0.4 MOMs, then there's a risk, right? Do you all understand? So if you look at the risk factors that comes during pregnancy, the baby can have problems or can have small for gestational age. Is that clear, children? So in your minds, remember, what are these? There are 2 large categories in the risk factors, right? What are these? One is current pregnancy complications, okay, which we look at it. It happens in the pregnancy itself, okay? Threatened miscarriage has happened. Anomalies, preeclampsia, pregnancy-induced hypertension, abruption, right? Unexplained APH. If the mother is not gaining weight, right? Drinking a lot of coffee, right? So all these are current methods which they can develop small for gestational age. And look at this, the upper part. At booking, in the history also, there are some indicators that the woman might have, right? See the age. If the woman is over 40 years of age, then the woman has a higher risk of developing a small for gestational fetus. While less than 35, more than 35, it's minor. Less than 35, it is not considered a risk factor. Okay. So then if it's a first baby, there's a small chance it might be a small for gestation. With subsequent pregnancies, the birth weights will become larger because the body is used to it. The uterus has already had a child, right? So therefore, it is not considered a risk factor. Okay. See, less than 20 BMI, very small mother, there is a risk factor. And then when the BMI, normal, moderate, normal BMI is not included. When the BMI becomes larger and larger, then obesity will also be a risk factor, right? Smoking a lot is a moderate risk factor, more than 11 cigarettes a day, right? If they are taking cocaine, the chance of small for gestational age becomes high because the cocaine is a potent vasoconstrictor, constricts the veins, the vessels, especially in the placenta. So therefore, they can have this risk factor, the small for gestational age, right? Look at this, daily vigorous exercise, if especially in sports women, right? If they do a lot of exercise, you can. Because I remember actually, I delivered a baby of one of our Sri Lankan athletes some time ago, right? Who was doing the relay, 100 meters relay. And she had a very small baby, right? Because throughout the pregnancy also, she was exercising, right? So, but it was a small healthy baby, okay? So that is also. Diet, of course, low fruit intake is a minor risk factor, but you can understand that maternal, in the mother itself, with the age, parity, BMI, whatever substance she takes, IVF, exercise, diet, that can cause small for gestational age. Okay. And then you ask for the previous pregnancy history. Look at this. If she had a previous SGA baby, she has a risk now. So we need to initiate surveillance. If there is a previous stillbirth, then the chance of SGA is higher this time, right? Previous preeclampsia and the pregnancy interval. Those are the things in the previous pregnancy history. Okay. If you look at the maternal medical history, all these, if she has in the medical history, right? She has a history of, there's a moderate risk of having a SGA fetus in this pregnancy. Look at this, diabetes, renal disease, APLS, hypertension, SGA. That SGA means if the mother was small, right? If the mother was a SGA fetus, then she also has a moderate risk of having a SGA baby. But at the moment, if she's having hypertension, diabetes, renal impairment, and antiphospholipid syndrome, then there's a moderate risk of having this. And if the father was also a SGA baby, right, then also there's a risk, right? So all in all, if you look at this, table, right, you have maternal risk factors, right? Previous pregnancy history, mother's maternal medical history, and paternal medical history. And current pregnant is a threatened miscarriage, fetal anomaly, preeclampsia, PIH, all this that happens there. You all understand? So all these risks are put as minor and moderate. And if there are 3 minors add up, then you initiate a surveillance plan. And if 1 moderate adds up, then you start off on a surveillance plan. Is that clear, children? So that is how you start off looking at these patients, right? Okay. Right. Now, so now we have assessed the risk factors for these babies, right? What is the next step? We need to initiate a surveillance plan. Right? Now, when we know that there is a problem, right? When there is a possibility that they might have a problem, what we do is we have to start checking out whether there's if the baby is going to SGA, right? And this is done by initiating what we call the protocol, or to check whether the baby is going to run in trouble, right? And what we do is we start doing ultrasound measurements, right? One moment. Okay, right. Sorry. Now, so once we have assessed these patients, right? Now we have to start the surveillance protocol, right? Now what do we do? What we do is we start, one of the important things that we do is to start the surveillance protocol by the 26th week, right? So there's something else that also we can do. Now, when we are approaching, normally small for gestational age doesn't happen initially. There are a lot of studies to say, okay, initially there are certain factors like the check the crown rump length. There are certain very subtle things that are done to find out whether there is a risk. But for us, that is not required to find out at the very initial stages. You all need not to understand this subtle. A lot of research is going on of trying to find small for gestation at the very early stages, like in the booking visit, at a crown rump length, initially at 9 weeks, 10 weeks. Those are at research level, but they will come, but later on, right? So our assessment should be at the booking visit, which I told you, or if they develop problems around the during the pregnancy. Now, one of the tools that we use, right, to find out whether they need to go on the surveillance platform or a protocol is the risk assessment, which I spoke to you about. Is that clear? So, and you take them as, okay, high risk, right? And then you put them onto a protocol. And this protocol starts at 26 weeks. Okay? Then there's another thing. If these women have these risk factors, which we have assessed from their history, there's one more screen test which we can do. And that is looking at the Dopplers or the uterine artery Dopplers at 22 weeks, between 22 and 24 weeks, right? And what does this mean? We are looking at the blood supply to the uterus itself. And what is a Doppler? So Dopplers, the talk about Dopplers is going to come up all the time, right? Now the Doppler is, we are measuring the blood flow through a vessel. And that is what is called a Doppler. And how is it measured? The ultrasound scan probe or the Doppler probe emits a sound wave, which goes and hits the moving blood. And it comes back. Then again, by the time it goes back again, the blood would have moved a bit, right? Because it is moving. And then it hits back and comes back. So there's a gap in the timing, because to hit one place for it to come back, and then if it again hits it at a different time, because it has moved, it will take a bit longer time for it, the wave to come back after hitting the moving blood particles inside. The difference is calculated, is called the Doppler, right? That is how the Doppler effect is calculated. So therefore, by looking at the differences, the time it takes for the sound wave to go there, come back. When it's further away, it takes more time to go there and come back. When it's more further away, it takes more time to go and come back. Since there's a difference in this timing, then the velocity inside the blood can be calculated, right? And it is put forward as a waveform. Is that clear? Right. So basically, Doppler is, we measure the velocity of liquids or blood or inside a vessel. Okay. And that is given to us as a waveform. So we look at it like a waveform and it comes on a monitor, on the ultrasound scan machine. Right. So when we look at the uterine artery Doppler between 20 and 24 weeks, right, in women who we have found to be high risk, sometimes a notch appears. So normal waveform, there is no notch. But here, suddenly, a notch appears between the systolic and the diastolic flow. Remember, children, during the systole of the mother, because uterine arteries, the mother is supplying blood to the uterus, okay? So when the uterine artery, during the systole, the blood is pushed forward with a bigger velocity. So we have a large waveform. During the diastole, the mother's heart is not pushing. It is passive. But because during the systole, a good push has been given, diastole also there is forward movement, but at a lesser rate. But sometimes, when there is a notch appearing between the systole and the diastole, which is called notching of the uterine artery Doppler, then it has been found that the baby is at a risk of becoming small for gestation age at a later gestational age, right? So therefore, one way of screening and finding out whether the baby is going to fall into trouble is looking at the uterine artery Doppler. Uterine artery Doppler significance later on, as time goes on, to predict fetal problems goes off after 24 weeks. We don't use it at all. You'll understand. It is like a screening tool to predict whether there are any problems in the future. So that is one way which you can put the women into a proper surveillance plan at a later time. Is that clear? Now, let's talk about the surveillance plan, right? Now we know that, okay, there are certain risk factors which I showed you. Sometimes in a high risk category, we can do the uterine artery Dopplers, right? And then all of them, we get a very high risk group of women whose babies may develop small for gestational age, right? Now we take all this category and start to assess their growth from 26 weeks onwards. Clear? And what do we look at? We look at two simple things. We look at abdominal circumference and we look at estimated fetal weight. Right? Okay. So we have a whole population of women starting from this, right, who will arrive at this surveillance program in different ways. Right? One way in which they arrive is looking at the history. We will, if they have several moderate risk factors or many minor risk factors, 3 or more, right, we will put them into the surveillance program. Is that clear? Right, which I showed you. Second, if they have all these problems or a lot of minor problems, then you do a uterine artery Doppler. And if there is diastolic notching or if there is uterine artery notching, you put them in the program. Okay. Then there's another category where when we measure the symphysis of fundal height, okay, and the symphysis of fundal height is smaller than the gestation age. So it's abdomen, when during abdominal examination, clinically, when the baby is small, right, then also we put them in the program. Okay. It is not a very sensitive method, especially in overweight women, women with fibroids, right, twins, that's difficult. But measurement of symphysis of fundal height also is one way in which you put the women, or we make you suspicious whether their baby is small. Okay, and you put them in the surveillance program. Okay, then, so all these ways, right, the women are put into a surveillance protocol. And the first initial surveillance protocol is done with what? We do the estimated fetal weight and the abdominal circumference for all these women who come into the surveillance program. Okay? And if the abdominal circumference or the estimated fetal weight falls below the 10th centile, then they are categorized as small for gestational age. Is that clear, children? Before we do the ultrasonic growth measurement of AC and EFW, we do not give them the name of a small for gestational age fetus, right? These are all screen positive people. The clinical screening, specified history, the uterine artery Doppler, right? Down, if the MOM, when you do Down syndrome screening, which and the Papa A is less than the some 0.4 MOMs, right? Papa M is reduced. So then all these are screening tools. And then suddenly they come to the ultrasonic growth measurement, and then we give them a diagnosis of small for gestational age. Is that very clear, children, how we arrive at that point? Right? And then when now suddenly we have a group of women or women who we have diagnosed as small for gestational age. Now we need to monitor them to find out which way they are going. Because in that group, there is a possibility there may be small normal babies. There may be abnormal small babies. And there may be babies who are going to suffer because of placental insufficiency and die. Right? You all understand now how the pathway is going. Right? And now, let's look at, now when the time we diagnose small for gestational age, the tool for monitoring children is umbilical artery Doppler. The tool for monitoring is Doppler. Is that clear? Doppler is not used for low risk categories, whereas there is no SGA, right? So the tool for monitoring the fetuses from the time we give them the diagnosis of SGA is Doppler. Number one. The second tool which we use is the AC, serial AC and EFW measurements. We do that as well, right? 3, we do MCA Dopplers, which we spoke about, middle cerebral artery Dopplers. So different kinds of Dopplers, right? And estimated fetal weight and the AC. So those are the tools which we use to monitor these babies and make decisions to deliver or not to deliver. Is that clear? Right. Then, next, right? Okay, one more, sorry. Take call. Right, sorry. Where were we? Yes, Nim sir, where were we?
AC, MCA, Doppler, and uterine artery Doppler.
Okay. Right. Okay. Let's summarize again. Right. I think Nim sir is a bit confused. So let's summarize again. Right. Now, children, get this into your head very, very clearly. Okay. Now, first of all, we think that there are babies that might develop small for gestational age in the future are the ones which, when we measure the symphysiofunnel height, right? And if the symphysiofunnel height falls below the 10th percentile, right? Then we call them clinically small for gestational age. And how do we plot the symphysiofunnel height? I'm talking about symphysiofunnel height, right? In the clinic. We have customized growth charts, right? And these customized growth charts can be downloaded on the web. So what do the customized growth charts do? They consider the ethnicity, parity, height, weight, everything you can put in the customer, and it prints out a growth chart for the particular woman, right? And it will show, okay, at this gestational age, the simplicity of fundal height should be this. Is that clear? So in the customized growth chart, when you measure the simplicity of fundal height, if the woman becomes, the baby is clinically small for gestational age, then we put them in the high risk category, and then we put them in the surveillance. We put them in the high risk category. That is one way which they arrive to get an ultrasound scan done. Is that clear? The second way to arrive at this point is when they do Down syndrome training, when we do, which we don't do often now, if the Papa A is lowered, then we think that yes, this woman baby might have a high risk of developing SGA, and they are put into that group. Or if the history, remember I showed you a chart, children, right, where there are moderate, minor risk. So if there are many minor risk factors, right, and if there are moderate risk factors, then they go for an ultrasound scan initially to somewhere around 26 weeks to assess whether there's a problem. Okay. Any point during the estimated simplicity of fundal height, or initially when they have biochemical markers, or by the history, right? And we find that there is a problem, we go send them for the ultrasound scan, right? So all of them will have an ultrasound estimation of what? Two things: abdominal circumference and estimated fetal weight, right? If the abdominal when done by ultrasound scan, if the abdominal circumference and the estimated fetal weight falls in the chart, now we are talking about AC and EFW charts, right? Not customized growth charts, which is simplicity of fundal height. That is initial screening. Okay. When you do all these patients, when they come, when you do the ultrasound scan for AC and estimated fetal weight, there are charts. And in that, if these babies fall below the 10th centile, then they are labeled as small for gestational age. Is that clear now? Right? So, although the simplicity of fundal height is small, and in the customized growth chart, the simplicity of fundal height was small, when they come to the scan and we find that the AC and the EFW is between the 10th and the 90th centile, they go back to their normal antenatal low risk screening. Is that clear? Even if the biochemical for Downs Papa A is low, even if they have minor risk factors and major risk, or even a major risk factor and all that, right? And they are sent for the ultrasound scan, and ultrasonically, right, if it is normal, then they go back, right? But in some cases, if they have a lot of moderate risk factors, you continue to monitor them, right? But they do not fall into very high intensive surveillance, because initially if the AC and the EFW is normal, then they are not really categorized as SGA. Is that clear? Now, once we find the category of babies who fall into SGA, which is less than the 10th centile, then what we do is all these SGA babies we monitor until delivery. Clear? And the initial most important surveillance tool for monitoring are the Dopplers. The uterine artery Dopplers, notching everything, will get them into the ultrasound to do the AC and EFW, okay? Right? But once we detect SGA, then they go into the surveillance categories, right? Now we do umbilical artery Doppler for these. So that is the initial tool now. When we do umbilical artery Doppler, we are looking at two things. What is happening to the blood flow during the systole, and what is happening to the blood flow during the diastole, right? And this umbilical artery Dopplers, these velocities are calculated by certain indices or indexes, right? Which are called pulsatility index and resistance index. Okay, this PI and RI, they are values which are calculated by mathematical formulas. Basically, what do they measure? They measure how resistant is the placental circulation for the blood flow through there. Right? What you have to understand, children, is the whole system is like this. The mother pushes the blood, right, to the baby, into the placenta. Okay. Now, the placenta is there, but there is no connection. In the sense, the blood does not directly go into the baby because the maternal circulation is on this side, the fetal circulation is on this side. Okay. Now, the fetal circulation, right? The fetal circulation is a low resistant circulation. Why is it? The baby's heart is central to it. The baby's heart pumps the blood. Okay. When the baby's heart pumps the blood goes and distributes along the body, and then it comes on to the internal iliac arteries. From the internal iliac arteries, the blood goes, right, to internal iliac arteries, the blood goes, right, and they become what? The umbilical arteries. The umbilical arteries originate from the internal iliac. So this blood is carried to the placenta by the two arteries, umbilical arteries emerging from the internal iliacs. Now, because the heart pushes it, now the blood is still going there. Okay. And then when the blood goes there, the blood has to go through the placenta. So the placenta has to be a very low resistance system. It can't be having high resistance because the blood has to go through the placenta, collect its nutrients and oxygen, and then the blood is collected via the umbilical vein, oxygenated blood. It needs to come back to the baby, goes up. It doesn't go to the liver, right? It's not very much interested in going into the liver. It circumvents the liver. What is that? Through the ductus venosus. Okay, ductus venosus. It goes up and fall into the right atrium. Now, because the baby's lungs are not working, because baby is getting all the blood, the lungs doesn't. So only a bit of blood goes there. So most of the blood falls from what? Falls from the right atrium to the left atrium. And then the oxygen blood falls into the left ventricle, right? And then most of that blood, when it's pumped out, is shunted, right? Some of it goes to the brain, it is important, but most of it is shunted onto the body, right? And what is this? Ductus arteriosus, right? It comes through the foramen ovale from the right to the left, is shunted again through the ductus arteriosus, circumventing the brain, right? So most of the blood goes to the body, to the brain, of course, right? Which are the vital organs, right? Brain, adrenal, liver, those are the vital organs. So it's supplied. Now, then again, the blood goes through, comes to the umbilical artery and goes to the placenta, right? Now, if the placenta, now this circulation works solely by the baby's heart. When it pushes, it has to go the whole round and come back. Right? Now, if the placenta that is standing in the middle of this whole system is high resistant, then the baby's heart, when it pushes, it will be difficult for the blood to travel through the placenta. So this has to be a very low resistance system. The placenta needs to be very, very low resistant. So therefore, when the baby's heart pushes the blood towards the placenta, right? And this blood goes through the umbilical arteries, and we look at the umbilical arteries velocity or the Dopplers or the blood flow must go very well. Do you understand? So the resistance should not be there, right? So therefore, the PI also should not be high. Okay. So all this, we are measuring the resistance of the placenta. So what happens? If the resistance goes up in the placenta, the PI also will climb up. It will go over the 95th centile, 90th centile. And that means the placenta is high resistance, right? So when we measure the blood flow, right, in the waveform, right, when the baby has a systole, the blood goes. So we should find a waveform. If there's no systolic waveform, that means the baby is dead. Okay, because the blood in the umbilical artery, blood must travel forward. Now during the diastole, the heart is passive. However, because of the push given by the systole, the blood continues to move forward, right, in the diastole. So we have a positive diastolic flow, but less than the systolic flow, there's a positive diastolic flow. Do you all understand? Because the blood continues to move. Because of the velocity given to it by the heart during the systole, because of the low resistant placenta, there is diastolic flow also through the placenta. And all the blood goes, oxygenates and goes back to the heart. Got it? But when the placenta has problems and the placental resistance is building up, what happens? The blood has to go through the systole, because when the systole baby's heart pushes, anyway the blood goes. Because if the blood is not going and return to the heart, the baby is going to die, right? But the diastole is passive. So when the placental resistance is high, slowly the end diastolic flow is reduced. And at one stage, what happens is the end diastolic flow becomes absent, right? Why? Systole is active, it pushes, but the resistance is so high, the blood stops at the diastole when the heart is not pushing. And then at some point, because the resistance is so high in the placenta, the blood in the diastole comes back, right? And what is that called? That is called the reverse diastolic flow. You all understand, children? Right? So we have a systolic and diastolic flow, then we have a reduction, then we have an absent diastolic flow, and we have a reverse diastolic flow. Okay? So that is how, after we have diagnosed SGA, right, and babies below 10 centile, then we do these Dopplers to find out whether the baby is in trouble. Got it? So these surveillance tools, after we diagnose this, right, there are three ways in which we go. The first category, what happens is, okay, when we monitor, if the umbilical artery Dopplers are normal, right, and there is a nice, although it is less than the tensile, but the growth curve is there. Okay, it is the growth, there is no faltering. It goes like this. In which case, we continue to monitor them, right? Every 2 weeks, we do umbilical artery Doppler, right? And then we do estimated fetal weight and AC weight. And then we find that they are growing less than the tensile, but no abnormalities, right? There is no abnormalities in the umbilical artery, so we continue to monitor them. However, they are small for gestation age, right? These babies, we normally will deliver them by about the 37th week. When they reach 37, even if the umbilical artery Doppler is normal, because they have been growing at the less than the 10 centile, but they grow along a trajectory without faltering, right? Then we deliver them by about 37 weeks. After about 34 weeks, for 3 weeks, right? If usually we do this every 2 to 3 weeks, right? The AC and the EFW. If there is growth faltering, if there has been no growth in these babies for about 2-3 weeks, then you deliver them after 34 weeks. Is that clear, children? And because we are delivering them before 34 weeks, we will give them steroids. So this is a category where it's SGA, but the umbilical artery Dopplers have remained normal throughout. Okay, no absent diastolic flow, everything is normal. Only the growth is small, but it is going on. But when there's growth faltering, we deliver. Is that clear? That is one category. The second category is where when we do the umbilical artery Dopplers, the PI and the RI is high. Now we have detected a resistance. In the first category, which I told you, there is the PI and the RI are normal, which means there is no placental resistance. Okay, but the growth is less than the 10 centile. So they are monitored and they are delivered at 37. If there's growth velocity change and if they're faltering, we deliver them. If for 2-3 weeks, if they're not growing, we deliver them after 34 weeks. Do you all understand? But the umbilical artery Dopplers are normal and there is no change in the PI and the RI. There is no placental resistance. Got it? The second group is suddenly we find the umbilical artery Dopplers are there. There is no problems with the diastolic flow. Diastolic flow is okay, but the PI and the RI indicates placental resistance. You understand the second group? Now we are looking at a small, a bit problematic than the other one, okay? Because the growth is also faltering, right? They're small, right? But also in the umbilical artery Doppler, we have seen the PI and the RI, which is high. So there's placental resistance, but still it is not resistant enough to stop the diastolic flow and reverse it. Okay. Now, when you continue to monitor these, you have to consider them more frequently, right? Those ones, other ones we did every 2 weeks. Now, these guys, we do the AC and the EFW, estimated fetal and abdominal circumference, 2 weekly, right? And we do the Dopplers twice weekly, right? Sorry, weekly. We do them estimated fetal weight and the AC weekly, and we do the Dopplers twice weekly. Got it? The first category, we do it every 2 weeks, right? This category, because there is resistance, we do the umbilical artery, Dopplers every two times a week, and the estimated between the AC we do weekly, and then we plot them on the graph. Okay. If the end diastolic flow, although there's resistance, does not reverse or become absent, we continually monitor this group, but we deliver them by 34 weeks. Got it? So this category, we deliver them by about 34 weeks. What is this category? AC and estimated fetal weight is below the 10 centile. Got it? However, they are growing along the line. But the umbilical artery Doppler, the pulsatility index and the resistance index is high, but there is end diastolic flow. These guys, we monitor them, and if it remains like that, we deliver them by 34 weeks by giving steroids. We deliver them earlier if they stop growing for 2 to 3 weeks, or they go into a higher risk category if when we do the umbilical artery Doppler, suddenly we find reversed or absent in diastolic flow. Got it? So now we have another group of babies. These babies, if they remain like that, we deliver them by about 34 weeks. We don't go beyond 34 weeks. Okay. Now, along this monitoring, suddenly we find that there is absent diastolic flow or reverse in diastolic flow. Okay. Now we have a third group of babies whose growth is less than the 10 centile in the umbilical artery, they have reversed and absent end diastolic flow. Okay. Now, the biggest problem is, what do we do with this? When do we deliver? Right? If the baby is about 27 weeks, 28 weeks, 29 weeks, right? Or 25 weeks or 26 weeks, right? If we deliver, the chance of cerebral palsy becomes very high also. So now you have to fine tune it to find out, okay, can we wait a bit more even with end diastolic flow, right? Absent or reverse end diastolic flow. For that, another type of Doppler is included, that is called ductus venosus Doppler. And what is the ductus venosus? Remember I told you, from the placenta, it's the umbilical vein goes and falls into the ductus venosus. It circumvents the liver and goes to the vein, right? You do the Doppler in the liver where the ductus venosus. So it's called a DV Doppler, ductus venosus Doppler. If there's resistance in that, right, then you have to deliver. Okay. So in these babies who have absent or reverse diastolic flow, right, what is the monitoring? You do AC and estimated fetal weight weekly, but you do the umbilical artery Dopplers and the ductus venosus Dopplers daily. And if there's an abnormality in the ductus venosus Doppler, right, then you deliver. Remember, if we reach 32 weeks without the ductus venosus becoming abnormal, you deliver these babies with absent or reverse diastolic flow. Is that clear? Before they reach 32 weeks, and if they develop abnormal DV Dopplers, you deliver. You all understand? So that is the principle behind it. So, however, you do not normally, if the DVs are abnormal, right? And if the baby is less than 32 weeks, but if the baby is less than 24 weeks, normally we don't consider delivery because there's a problem of the baby's chance of cerebral palsy is very high. So that is very controversial because things are coming up. But the principle is, if the ductus venosus Dopplers, even if it is normal, however, if there's absent or reverse diastolic flow, then you deliver by 32 weeks. Before 32 weeks, you deliver if the ductus venosus Dopplers are abnormal, right? So this is the principle that for the moment that we are going on of managing these small for gestational age babies. You all understand? So what I want you to do is to go to the RCOG website, okay? And in the RCOG website, there is a guideline, it's a bit old, right? Which gives the flow chart for the Doppler, for this management pathway, right? So download I will put the link for you all anyway in that. Download that and then download that risk chart, right? And download that pathway, which I just explained to you. Is that clear? So this is the way in which we manage small for gestational age babies. Okay. So let me summarize, right? Let me summarize how to manage the small for gestational age. Number one, when the women come into the antenatal clinic, okay, you look at the history, right? In the history, there are minor and moderate risk factors. So if the woman is having 3 minor risk factors or 1 or 2 moderate risk factors or a mix of these, you call them high risk for having a small for gestational age baby. Okay. In which case, in some countries, they will be subjected to a uterine artery Doppler. And if there is notching, then they are considered high risk. Or even with the history, they can be considered high risk. Right? And these women are directed to have an ultrasound scan, right, at 26 weeks. So they go into a surveillance at 26 weeks. Okay. Then there's another category of women who will come into this step, right, for an ultrasound scan, right? These are the women whose down screening, which are done in other countries, right, where the PAPA-A is found to be low. They will also be put into screening for as a high risk for or having a risk for small for gestational age, right? The third other category that comes in, right, are the ones who are when we are measuring the symphysis of fundal height, and that symphysis of fundal height is deemed to be smaller if we chart it on a customized growth chart, and the symphysis of fundal height is small, then they are also deemed high risk for small for gestation age. Do you understand? So they all arrive for the screening ultrasound scan to see whether they are ultrasonically small for gestational age. Is that clear? When that scan is done, when they are ultrasonic, then if we find that the AC or the estimated fetal weight is below the 10th centile, then they are called small for gestation age fetus. Now, this cohort of babies are monitored by umbilical artery Doppler, okay, and serial AC and EFWs, right? Now, one group will proceed like this. Serially, AC and EFW is normal and the umbilical artery Doppler is normal, right? There is no placental resistance. These babies we will monitor every 2 weeks with AC and every 2 weeks Doppler, and if they will proceed, but normally we don't go carry them beyond 37 weeks. However, with the normal Dopplers, no placental resistance, if there's growth faltering, when the chart goes right, but they falter growth for 2-3 weeks, if there's no growth, you deliver, even before 37 weeks. Got it? Right. Now, as things go along and in the surveillance, because you are doing 2 weekly, right, Dopplers, and then suddenly you find that the pulsatility index and the resignation have gone up. So growth is growing, but the PI and the RI has gone up, which means they are developing placental resistance. Suddenly, you put them into what? Okay, now we will check the estimated frequency every week, and we'll do the Dopplers every 2 weeks. And they go along that, right? And when they go along that, if they reach 34 weeks, you deliver. Before 34 weeks comes, if there's growth faltering, right, and the baby is not growing, then you deliver, okay, by giving steroids. Now, as we go along this pathway, and if you have not reached 34 still, because at 30, when you're going along that pathway, by 34, you deliver, right? Say by about 30 weeks, suddenly you find they have absent diastolic flow or reverse diastolic flow. Then what you do is, you start doing Dopplers daily. But to that, you add ductus venosus Dopplers. Now you have a category of women with absent diastolic flow, reverse diastolic flow, and ductus venosus Dopplers. If you can add computerized CTG, that is good, but we don't have that, right? And then if there is any abnormality in the ductus venosus Doppler, because already there's absent or reverse diastolic flow, then you deliver even before 32 weeks, right? By going along this pathway, if you can go up to 32 weeks, then you don't wait beyond 32 weeks. Even if the DV is normal, you deliver. Do you all understand? So that is the practical pathway which we go along monitoring these babies. So you make it more and more and more and intensive, and you take the delivery decisions depending on these parameters. Is that clear, children? Right? So this is the practical way in we manage small for gestational age fetuses. Okay? Is that enough? Did you all get a good understanding? Right? So RCOG guidelines go for small for gestational management of small for gestational fetus. I will put the link. You need to read through it, but you need to look at two things. One is the risk factor chart, clinical risk factor screening, and the second is the pathway, which should be clear to you all now. right, of managing a SGA failure. Those two you look at it, that is more than enough for you all. Okay, right. Then, any questions? You can ask any questions if you want. If you want, you can type the questions. Fully understood? Excellent. Right, okay. Okay, what do you all want me to do next time, children? What do you all want me to do? Now we have done quite a lot of obstetrics, right? We have done, I did 3 or 4 heart disease. Then we did SGA. I hope that was clear, right? SGA. Is SGA clear now in your minds, right? And what do we do? Do you want to do gynecology next one? What do you all want to do? Yes, yes, come up with something. Either you all know everything. Yes, Malita, Hettige. Tell me, what is the topic you want, Puta? Say something. Yes, Nim sir. He has a huge library behind him, so we will ask him. He looks like a very educated young man. Yes, Nim sir.
So malignant condition of cervix.
Didn't I do those malignant? I mean, malignant, or did we do pre-malignant lesions?
Yes, sir.
Yes, sir.
We did pre-malignant lesions, no? And then I've done endometrial CA.
Yes.
So you want cervical cancer, is it? Malignant?
Yes,
all right, okay. So we'll go along the pre-malignant. Pre-malignant, did I do cervical pre-malignancies? Or all? Nimsara, can you check what I did and tell me tomorrow or day after, right? I have just written pre-malignant lesions. I don't know whether I covered cervical, endometrial. Did I cover everything or did I just cover the cervical pre-malignant lesions? Okay, you check and let me know, right? So we will do malignant lesions of the cervix next time. Okay. Any other suggestions? Yes, Oshadi?
That's good, sir.
What is good?
The malignant lesions of the cervix.
Cervix, yeah, okay. Any more suggestions? Yes, Mr. Nadish?
Sir, amenorrhea.
Amenorrhea.
Yes, sir.
What type of amenorrhea are you referring to? Primary or secondary?
Primary, sir.
Okay. Okay, that is the second topic. Okay. Yes, Mr. Varuna?
About the carcinoma is
You all like carcinoma. Okay, right, fine. Okay. So next week I will do cervical carcinoma, right? Is that what you all want me to do? Okay, fine. So we'll do cervical carcinoma. Okay then, right. There's someone in the chat, somebody has typed in. is there a preference of the mode of delivery? Right, okay. Now, for gestational age, the problem is, remember I told you there's a category of babies whose growth is going along the less than the 10th centile, right? And there's no growth fault, or maybe there may be growth fault, but the umbilical artery Dopplers are normal and there is no resistance. The PI and the RI, resistance and the pulsatility index are normal. In these women, yes, we can actually try for a vaginal delivery if everything else is normal, right? So anyway, since we are going to deliver them before by 37 weeks with steroid cover, right? And if necessary, all these women also can have neuroprotection by giving magnesium sulfate. What are things we can do? We can give steroids, right? And we can give magnesium sulfate for neuroprotection. You all know that, right? Right? The things we can do actually. Actually, there's only small amount of things we can do actually for these women to prevent that I forgot to actually talk to you about, right? Wait, I will. Right. There are only few things which we can do, right, to improve this problem, right? Number one, what we can do is, if we are going to deliver, there are few things we can do. One is to give steroids, children, if there is time, okay? Second thing is when the fellow is coming out and if it's very preterm, to give magnesium sulfate for neuroprotection. Third thing is to deliver them at a place where there is very good support, neonatal support. The things we can do before they are born to produce it, right, small is, if there are conditions, I told you there are moderate risk factors, high risk factors in preeclampsia, right, and pregnancy-induced hypertension. If we do things that we can prevent preeclampsia, then you can prevent a certain amount of small for gestational age, like giving aspirin. Aspirin 150 milligrams before complete trophoblast invasion takes place will reduce the number of preeclampsia and pregnancy-induced hypertension. In that, in turn, will reduce the amount of SGA fetuses, right? That is one preventive measure which we can do, okay? Then, of course, if they, very rarely, if they take a lot of coffee, right, you can ask them to stop taking coffee because that is a risk factor, caffeine. If they are on cocaine, right, that is something that can be done to prevent SGA, right? To if they can stop that, okay, which is unlikely. If the woman is exercising very much, right, like for competitive sports, maybe reduction will reduce the chance of getting a SGA, right? So those are some modifiable risk factors which we can address if you want to prevent SGA. So if you ask, okay, how do we prevent? Right, those are the things that we can do. Nothing much, okay? And then the mode of delivery, of course, remember the first category where the growth curves are there, the umbilical artery Dopplers are normal, there is no increase in resistance, those we can go for, try for a vaginal delivery. But at 37, the cervix will not be favorable. So you have to put prostaglandins with intensive fetal surveillance, right? You can try for a vaginal delivery. But the other two categories, because if we are trying to deliver them before 34 weeks, like which category? Either there is growth faltering or there is high PI and RI, right? And we have reached with present diastolic flow, but we have reached 34, then we have delivered. Those patients, usually it is by cesarean section, because even if we start to induce, the labor might not progress. So normally it is by cesarean section. The other category, where is absent of reverse end diastolic flow with normal ductus venous Dopplers, and if they have reached 32, you deliver. But usually by 32 weeks, even if you induce there, it's very difficult. Usually it is by cesarean section, right? As you understand, we are trying to deliver at 32. And of course, if when there is absent or reverse diastolic flow, but the DV Dopplers also become problematic because we are there in the way, and if there's high resistance in the DV as well, right? DV Dopplers, right? There's no blood flow, not going very sluggishly towards the heart. Then of course, it is also a cesarean section because you are even delivering them even before 32 weeks. You need to be very careful before if you deliver them before 24 weeks because the chance of survival is very small. So some countries, well, okay, if the period of gestation is less than 24 and the borough weight is less than 500, sometimes you might not deliver. You might just allow it to go on and have a miscarriage, right? But anyway, the principle is what I told you. So the mode of delivery, predominantly cesarean section for these babies, except that category where if we are gone up to 37 weeks, then there's a possibility we can do a vaginal delivery. Okay? Does that answer your questions? Any more questions? Right, then, good night. It's late also. No, 11. Okay. Okay, right.
Good night, sir.
Bye.
Thank you, sir.
Thank you, sir.